Hello, I'm Alessandro Di Federico. I'm a thoracic oncologist from Italy, and it is a pleasure for me to present this study that was accepted for poster presentation at the ESMO 2024, entitled First-Line Immunotherapy versus BRAF and MEK inhibitors for patients with BRAF V600E mutant metastatic non-small cell lung cancer. First-line targeted therapy with BRAF plus MEK inhibitors is effective in patients with advanced non-small cell lung cancer harboring the BRAF V600E mutation. Differently from other oncogene-addicted non-small cell lung cancer population, patients with BRAF-mutated non-small cell lung cancer are more commonly smokers and derive benefit from immune checkpoint inhibitors therapies plus or minus chemotherapy. However, most guidelines, such as the NCCN and ESMO guidelines, recommend a first-line treatment with BRAF plus MEK inhibitors, despite the absence of head-to-head comparisons with IC-based therapies. So in this study, we collected clinical pathologic and outcomes data from patients with metastatic non-small cell lung cancer treated with first-line immunotherapy plus or minus chemotherapy or BRAF plus MEK inhibitors between 2015 and 2024 across 6 centers in Europe and United States. What we observed is that in terms of overall survival, there was a numerically longer median overall survival among patients who started with the immunotherapy plus or minus chemotherapy. 35 patients, and the median OS was 43.3 months versus 23.3 months in 76 patients who started with BRAF inhibitors plus MEK inhibitors. And when looking at clinically relevant subgroup, the overall survival is subgrouped based on tobacco use history, PD-L1 tumor proportion score, and brain metastasis. We observed a trend towards better outcomes with immunotherapy plus or minus chemotherapies among heavier smoker, namely those with a greater or equal than 30 pack years, those with high PD-L1 expression, tumor proportion score or greater or equal than 50%, and patients without brain metastasis. When looking at the safety of BRAF inhibitors plus MEK inhibitors by line of therapy, and specifically whether these treatments were administered as a first line or as a second line after a first line treatment with immunotherapy plus or minus chemotherapy, we observed an identical rate of adverse events of any grade that was 73%, and an identical rate of grade greater or equal than 3 adverse events that was 23% in both scenarios. So in conclusion, our study suggests that individual clinical factors should be used to tailor their first-line treatment choice in patients with advanced BRAF V600E mutant non-small cell lung cancer, including tobacco use history, PD-L1 expression, and metastatic sites. Additional analysis to better define the optimal therapeutic sequence in this population will be conducted. Thank you.